Welcome to the inaugural episode of Florida Society of Nephrology podcast. I'm Dr. Nabeel Aslam, President of the Florida Society of Nephrology and a consultant nephrologist at Mayo Clinic, Florida, and I'm honored to serve as your host for this new initiative. This podcast was created with a simple but important goal, and that goal is to spotlight the outstanding scholarly work being done by nephrologists across Florida, from innovative research and quality improvement projects to advances in education and patient care. Every day, our colleagues are developing new ideas, improving clinical practice, and finding better ways to serve patients with kidney disease and hypertension. Too often, these efforts remain local stories. Our goal is to create a platform where those advances can be shared, discussed, and expanded through collaboration. Through conversation with researchers, educators, and clinicians from around the state, we hope to strengthen connections within our nephrology community and inspire collaborations that advance research, education, and clinical excellence for all FSN members. Thank you for joining us at the beginning of this journey. If you or anyone you know would like to be part of this podcast, please reach out to me. My email is aslam.nabeel@mayo.edu. We are excited to learn together, collaborate together, and continue advancing kidney care across Florida. Let's get started. I'm excited to welcome Dr. Fouad Chebib today to discuss his recent publication in Kidney International Reports on autosomal dominant polycystic kidney disease. Dr. Chebib is professor of medicine at Mayo Clinic Alex School of Medicine. He is the director of the Mayo Clinic Florida PKD Center of Excellence and the director of Discovery and Translational PKD Research Lab. He also serves as the research chair of Division of Nephrology and Hypertension. Welcome, Dr. Chebib.
Thank you, Dr. Aslam. Thank you for having me.
Excellent. Before we jump into your recent publication, could you start by telling us a little bit about yourself and what drives your passion for improving the lives of polycystic kidney disease patients? And hopefully, I know you're very passionate about finding the cure for this condition.
Thank you, absolutely. And thank you again for having me on this inaugural podcast. Congratulations to the Florida Society of Nephrology and to you, Dr. Aslam, for your leadership. This is a great initiative, and I think it will bring our Florida colleagues together and understand the great work being done across the state. So I'm a nephrologist, and I like to call myself a PKD nephrologist, as I try as much as I can to subspecialize and take care of PKD patients, not only in clinic, but also through our research that we are doing in the clinical space, but also in the translational and basic science and discovery space. I got differentiated into nephrology and more so into PKD very early on, even before medical school. This is a bit of a personal story where my father reached kidney failure because of autosomal dominant polycystic kidney disease. And at that stage, I just decided when I was a teenager that I'm going to become a doctor, a nephrologist, and a PKD nephrologist at the Mayo Clinic, and with the goal of helping as much as I can up to the moonshot or the dream of curing the polycystic kidney disease and helping families. So hopefully we're getting closer and closer every day. And since I moved to the great state of Florida about 4 years ago, I feel like we have that big goal in front of us, and it's potentially achievable. If I don't want to say definitely achievable in the near future. So we're excited for the prospects in this space. Thank you.
What an inspiring story. Thank you for sharing your personal insight, what made you become a PKD expert. So your new paper in Kidney International Report focuses on characterizing the ADPKD IFT 140 phenotype signature using deep learning and advanced imaging biomarkers. We often hear about PKD1 and PKD2 mutations in ADPKD. Could you walk us through some of the other mutations which are identified in ADPKD patients and let us know what proportion of patients have an identifiable genetic mutations in patients who are diagnosed with polycystic kidney disease?
Yeah, definitely. So we're in a really exciting era with the advances in AI and imaging and our ability to extract new biometrics from the data that we have for our patients. So this PKD is a really a poster child and really individualized medicine in 2026, and PKD is heterogeneous in terms of the genotyping. So it's not only one type of mutation or not only one gene that can cause autosomal dominant polycystic kidney disease. In fact, there's now about 10 genes. Now, the majority of the cases are going to be PKD1 and PKD2. So PKD1 is about 78% of the cases, and PKD2 is about 15% of the cases. Just kind of a little bit of a background, as you know, autosomal dominant polycystic kidney disease is a monogenic disease. It's an inherited disease that leads to hundreds and hundreds of kidney cysts, enlargements of these kidneys on both sides, and eventually leading to kidney failure. So that's the traditional or the classic autosomal dominant polycystic kidney disease. Again, almost like 93% of the cases are those cases that you're all familiar with. Now, there's a smaller portion that we are now discovering year over year that they are also called autosomal dominant polycystic kidney disease because they have the phenotype of multiple kidney cysts on both kidneys, but they look a little bit different and their clinical trajectory could be different. Now, in the past, we used to call them no mutation detected because the panel and our understanding of the genes was we haven't discovered these genes yet. So, over the past, I would say 5 to 8 years, those additional 8 genes have been discovered, and now they're part of the gene panels that we offer to our patients, and also having genetic testing readily available to almost all of us across the state of Florida. uh, Now we're understanding more and more these entities. So what are these, what we call minor PKD genes? So they have different names of genes. So I'm going to get you familiarized a little bit with them. So IFT 140 is one of the genes, similar to PKD1 and PKD2, can cause autosomal dominant polycystic kidney disease. So only having a pathogenic variant or a mutation in one allele in IFT 140 gene can cause too few kidney cysts on both kidneys. And we'll talk a lot about that phenotype and that characteristics of this particular entity. But as a background, there's a few others. So GANAB, GANAB, is another gene that can cause a mild form of polycystic kidney disease. There are other ones like ALG, ALG8, ALG9, ALG5, as well as NEC8, NEK8. So we're not going to go into big depth of the other ones, but just to give you an idea that now we have really a variety of genes that can cause autosomal dominant polycystic kidney disease. And we'll talk more today that uh, it's becoming very important to be very specific on our diagnosis because it's going to affect how we're going to inform our patients about the clinical trajectory, what's going to happen for their kidney function in the future. So that's really a practical, important aspect. But more importantly, now we're having new therapies that are very specific to certain types of PKD. And so it's going to affect your management in terms of offering certain medications or not offering or gearing them towards clinical trials that are very specific to subtypes of PKD. So that's kind of the big idea of minor PKD genes.
Wonderful. Thank you for explaining that. And as I learned from your paper that IFT 140 is now the third most common disease causing variant in autosomal dominant polycystic kidney disease after PKD1 and PKD2, what prompted your team to focus on this IFT 140? And why do you think it is clinically important for nephrologists to be able to recognize this particular variant?
Yeah, so as you mentioned, IFT 140 is third in line after PKD2, but it's also important to share with our audience that it's only 1 to 2% of the cases. So despite being called the third most common, it's still a rare entity. Now, I think that number might go up a little bit as we get more genetic testing in more of our patients. but it still is going to be a small subset of ADPKD patients. Now, the reason why we went on and tried to characterize this subset is as we see patients in our clinic and we open their imaging, whether an MRI or a CT scan of the abdomen or an ultrasound, these various ADPKD patients have different phenotypes radiologically. So when we look at the case and we see few kidney cysts, so smaller number of kidney cysts, and these cysts are larger in size, then almost immediately I would say this looks like a phenotype of IFT 140. So that kind of was the driver for me to find the objective way of putting together this phenotype, or what I call a phenotypic signature or radiomics. So the reason why we went on and used the tools that we have with artificial intelligence and machine learning is now it's becoming available to us to get a lot of characteristics, a lot of the metrics extracted um, from these imaging. And I think it's very helpful for us to, again, be very, very specific in nephrology these days to have the accurate diagnosis. And it was one way for me to bring kind of these patterns that I developed in my mind as I see more and more of
Hmm.
ADPKD patients, to bring them more on how can we make it practical for our trainees, our fellows, our junior faculty to also pick up on these patterns, and just when they see the imaging, they'll be like, yeah, this looks like IFT 140. So that was kind of the goal of this paper.
Oh, that's fantastic. So, as I was reading your paper, one of the standout finding in your study was the distinctive imaging phenotype, which you were trying to describe in just a minute ago, that there are fewer, but there are bigger cysts on the kidneys, and there are not much cystic involvement of the liver in most of the patients. How do you think these imaging characteristics can help clinicians distinguish IFT 140 patients from classic ADPKD? What kind of recommendations would you give based on this study? What they should be at a lookout for?
Yeah. So it's very distinctive that how the cysts look like for IFT 140. So just to kind of maybe a step back, one step here. There's a classification through imaging that we call the Mayo Imaging classification that was developed up in Mayo Rochester, Mayo Clinic in Rochester. And the classification is we would call either class 1 or class 2. So class 1 is the typical ADPKD where you have bilateral kidney cyst, and all these cysts are almost equally contributing to that total kidney volume. So imagine in your mind kind of a classic case of ADPKD where you see these 100 cysts. They could be small to medium size, but you don't see just like 4 or 5 huge cysts. So that's typical where almost all these kidney cysts are contributing almost equally to the total kidney volume. And that compares to class 2 or the atypical. So Mayo imaging class 2 is it's a potpourri or a variety of things where there's some asymmetry or some atrophy. And one of the asymmetric cases, it's called lopsided. So lopsided, by definition, is 4 or less cysts are accounting for 50% or more of the total kidney volume. So in other words, this is saying that you have 4 or 5 cysts that are really, really big, and that's why the total kidney volume is large. And you need to be careful that this is not the same as having hundreds of cysts with the exact same total kidney volume. So that in that background, IFT 140 almost similarly follows that lopsided Mayo Class 2A. The asymmetric, not the asymmetric, but more the lopsided, where you have few large cysts.
Mhm.
So, in my mind, instead of just having kind of this very strict rule, I thought, okay, maybe we can have a more of a continuum and more of an objective way of doing that. So the specific really phenotype, as you mentioned, is maybe 2 or 4 cysts that are quite large. So maybe either on ultrasound or CT scan or MRI, when you measure these very large cysts, you'll have maybe 5 centimeter cysts, 6 centimeter cysts, or even larger. And you have 3 or 4 of these, but they will account for a much larger dimension of the kidney, whether kidney length of 16 centimeters but it's really 16 centimeters because you have one or two very, very large cysts. So these type of phenotype, when you look at them, you see also that the kidney parenchyma is preserved, and you know, as a nephrologist looking at this, you're gonna know that the clinical trajectory is much milder, and they're not gonna reach kidney failure because they still have quite a bit of preserved parenchyma, despite on number by numbers, the total kidney volume is large. So that's why I think knowing these characteristics will be very, very helpful in routine practice because you're going to be able to tell the patient, well, your case looks atypical. Let's get genetic testing based on the imaging phenotype. You look atypical, so let's kind of confirm that with genetic testing and we'll confirm your clinical trajectory.
That's very, very important and a good lesson for the practicing nephrologist to look at the images and seeing if it's a lopsided or fewer cysts, which are very big, but there are multiple cysts on the kidney. And as you pointed out in your paper, that the kidney function decline in this IFT 140 patient seems to be slower as compared to PKD1 or PKD2 associated disease. So how do you think this finding will influence the prognosis discussion with the patient, counseling, treatment strategies? And is tolvaptan still the option for these patients to further slow down the decline in kidney function?
Great question. Yeah. So IFT1, so ADPKD patients with IFT140 mutation, they will do very well. So it's a good day for me to tell them, well, you have a very good prognosis. Yes, you might end up with chronic kidney disease at older age, but if we don't have any other contributing factors like diabetes or something else that will affect the kidney, we don't anticipate that you're going to reach kidney failure, but you will reach maybe chronic kidney disease stage 4 in your 80s, for example. So that's the trajectory that's going to be even milder than PKD2, but also very rarely we're going to see kidney failure in this subgroup. So that by itself tells you that these particular patients are slowly progressing, so they're not at risk of rapid progression or reaching kidney failure at earlier age. And for that reason, that's the change in the management that you're not going to offer them disease-modifying treatments such as tolvaptan, which is right now the only FDA-approved treatment to slow disease progression in ADPKD. And the reason why we would not offer tolvaptan is these patients, we don't anticipate they're going to reach kidney failure. So why do we need to expose them for decades of treatment that has its own side effects or peculiarities? So at the moment, since we don't have any specific treatment, or we don't need actually any specific treatment beyond just the general measurements that we do for chronic kidney disease and chronic kidney disease and ADPKD. So blood pressure control, good hydration, avoiding non-steroidal anti-inflammatories, good blood pressure control, um, and just the general management with making sure we have normal body mass index. So the things we do for all ADPKD patients up to reaching tolvaptan. So we would not recommend tolvaptan for these patients.
No, this is an excellent point that these patients don't need the tolvaptan, and not only the side effects, but the cost associated with that medication can be avoided once we know that this is the phenotype we are dealing with in our clinical practice. So that was a very important finding from your paper. And your team developed this deep learning model and a practice model using imaging measurements for identifying this IFT 140 patients. For clinicians who might not have access to these advanced AI tools, how feasible is it for them to use the practical model or for that matter, deep learning model? And how do you see these being integrated into everyday nephrology practice?
Yeah, great question as well. And it's always something in the back of our mind that if we develop new tools and they don't reach the hands of every practicing nephrologist, then we're not successful. So that's always top of our mind, actually, not only in the back of our mind. So right, but first we need to develop these tools, and second we need to disseminate them to the best of our abilities As you mentioned, we developed with a strong collaboration with our imaging core up in Mayo Clinic, Rochester. So that's been an ongoing effort for more than a decade, starting with automation of total kidney volume and now going into that more in-depth advanced kidney imaging. So getting the total in addition to total kidney volume, getting total cyst number, getting each cyst, how big it is, what's the surface area touching the kidney parenchyma, getting the parenchymal volume. So all these metrics used to take 1 to 2 weeks actually, and manual effort from one person to do it. And with the advancement of machine learning and AI, and with the help of many great fellows and colleagues on campus and in Rochester, we were able to automate this process. And that helps us make this more feasible in our hands. And within a few minutes, we can quality control what the AI is giving us, which is segmentation. So the AI would see the kidney on MRI and would understand this is first cyst, this is the second cyst, third cyst, and it would color it in different colors. And then we just need to make sure that the boundaries were correct and it didn't pick up on something else. So that's the process in the deep model to give us all these tools. And we're hoping it's going to be some web interface that anybody can upload these images and get back these results immediately. But until then, we thought in this paper, how can we make it practical for nephrologists who don't have access yet to these tools? And within the model that we've done is we said this is a best case scenario where you have all the metrics and it's quite advanced and there's a very sophisticated formula to get a threshold to say okay above if your biggest cysts are contributing to a large volume of total kidney volume. So for example in this cohort that we have those 27 patients of IFT 140 were compared to about 100 patients with PKD2 and about 170 patients with PKD1 non-truncating and 300 patients with PKD1 truncating. And just to give you an idea that we looked at, again, that phenotype and said, what is the cumulative volume of the two largest cysts in relation to the total kidney volume? And to start with PKD1 truncating, the two biggest cysts would account for about 6% of the total kidney volume. Same thing for PKD1 non-truncating, and then maybe PKD2 they have a little bit larger cysts, so about 10%. The biggest two cysts will account for 10% of total kidney volume. So that's kind of the typical ADPKD, right? And then now compare it to IFT 140, and we saw that on average, the two largest cysts will account for 30%. So 30% as compared to 5 or 10%, right? So that's very substantial. And we said, can we use this finding to make it practical where you're in the clinic, you're busy, you just open up the image and just kind of measure the two largest cysts in diameters, and we were able to get the formula that all you need to do is get a diameter of the two largest cysts on your imaging, and we have a threshold around 18% based on a formula that we have in the paper. Very easy formula, doesn't need a lot of calculations, and we have that threshold that if you see that those two larger cysts are beyond this threshold, this will gear you towards saying this is potentially an IFT 140 case. Let's get deep dive on the genetics and obtain a genetic testing and confirm it.
That's very important. That's a good tool for us to remember that if we're looking at the images and these are a big cyst, you can just measure two biggest one and use that simple formula to get the indication whether we are dealing with this mutation. So just to wrap up, I have one more question I would like you to answer for our audience, and that is looking to the future, what are the broader implications of being able to better phenotype and classify the genetic subtypes of ADPKD? Do you see this moving the field closer to more personalized approaches to monitoring, maybe clinical trial design for these special entities and the treatment selection?
Yeah, great question. And um, Yeah, in 2026, I think there's two things each ADPKD patient should get. One is genetic testing and figure out not only if it's PKD1, PKD2, or these other minor genes, but also understand the specifics of each of them. So is it PKD1 non-truncating? Is it a missense mutation? The reason why I specify this particularly is there are now new therapies in clinical trials that are very specific to a certain region in the PKD1 gene. And if your patient has a missense mutation, for example, in a particular region, they could be treated with a specific treatment that is a genetic therapy. So that's called the polycystin 1 corrector. So there's a lot of advancements coming our way. This field is going to evolve extremely fast. Every 6 months to a year, we're going to have a different set of new things coming our way. So keep stay tuned on all these big advancements. And that tells you that, we're going to have a more personalized approach since we're going to have new treatments for specific types of mutations. So my recommendation for everyone in Florida is let's work together to characterize our patients and get them ready for these clinical trials. So one is these genetic therapies. Two is also there's more genetic therapies coming as a phase three. Those are under the skin, so subcutaneous injection every 2 weeks, trying to increase the level of the polycystin 1 and polycystin 2. So this is very exciting, not only for PKD or nephrology, but actually for all medicine, because this is very, very new, and PKD is the first uh, in this class to proceed to phase three and hopefully show efficacy. So lots of things happening. The more we understand where our patients uh, where they are, what's their clinical trajectory, what's their predicted clinical trajectory, then we can either prescribe tolvaptan or refer them to clinical trials. And the more and more we understand about what's going to happen and how we can help them, the better off we are with our patients.
Oh, that is exciting. This is exciting time for nephrology with lots of development in polycystic kidney disease and glomerular disorders and in lots of other areas. So we are entering a new era in the treatment of our patients with kidney disease. So as we wrap up today's episode, I want to sincerely thank Dr. Shabib for joining us and for sharing the insights and impact of his this important publication. Discussion like these are exactly why we launched this podcast to highlight the outstanding work which is being done by nephrologists across Florida and to foster collaborations that advances kidney care, research, and education. I also want to thank you for listening to this podcast. We hope these conversations provide new ideas, spark collaboration, and strengthen our nephrology community. And finally, if you or any one of your colleagues would be interested in being featured on a future episode to discuss your research, educational initiatives, or clinical practice improvement work, I would love to hear from you. My email is aslam.nabil@mayo.edu. My last name dot first name at mayo.edu. The Florida Society of Nephrology podcast is meant to be a platform for sharing the innovation and excellence happening throughout our state. Thank you again, and we look forward to sharing with you the next episode of FSN podcast.